Welcome, everyone. Depending on which time zone you are, good morning or good afternoon. We're here for another webinar going through one of our Pine sessions. And for those who haven't attended before, generally what we do in these sessions, they're meant to be fairly interactive. We have a case presentation and then some discussion with our experts that we'll introduce, and then go through the case as well as some of the literature and hopefully have a fun discussion over the next hour. So my name's Christina. I'm a respirologist from the University of Calgary in Canada. We're excited to present several of our individuals today. So our case presenter is going to be Alexandria Imperto from NYU, who is a pulmonary critical care fellow. And we're very excited to have two guest experts who are going to help us with our discussion through the case. Dr. Scott Evans from MD Anderson and Dr. Marcus Restrepo from the University of Texas Health Center. So as we go through the case, there are going to be several questions that get posed to the audience. We really would encourage feedback and interaction because that's what makes the case fun. And then we'll be really excited to hear the discussion Alexandra presents, as well as the expertise from our experts. So with that, Alexandra, I'll turn it over to you and you can go ahead and get started.
All right, good afternoon, everyone. Thank you so much for joining. So the topic today that we'll be discussing is entitled Community-Acquired Pneumonia and Why is My Patient Not Responding? I think this is going to be a great case because pneumonia is certainly the bread and butter of what we do whether we're in pulmonary critical care, infectious disease, hospital medicine. And I think that sometimes we sort of expect folks will respond to the very straightforward evidence-based guidelines, and then it's worthwhile talking about what happens when that doesn't happen and why it might be happening. So we'll start off with the case. So this is a 52-year-old gentleman who presented to a Calgary hospital in December 2023 with cough productive of sputum, myalgia, dyspnea, and cough. He has a past medical history of hypertension and type 2 diabetes. He has no pertinent surgical history. His family history is non-contributory. And I believe we had a Zoom question supposed to be coming in. And so just, I sort of asked this as yes or no, but would be interested to hear from the audience if there's anything. Oh, sorry, I think we missed question one, but. Question one was actually about whether there was anything in his past medical history that we would consider informing our differential diagnosis to begin with. Does his diagnosis of hypertension, type 2 diabetes, or neither make us think differently just on first pass of this patient?
Maybe while the question is loading, maybe I'll just ask Dr. Evans. Just hearing this very brief story, is there anything that jumps out at you with the past history? It seems like our audience is a bit torn between diabetes and neither.
Yeah, so this is a great question, and it's one that we continue to struggle with quite a lot, which is what do we do with things like metabolic syndromes and diabetes? Where do we categorize those? We've gone through a couple major ATS episodes recently where we struggled to define what constitutes an immunocompromised host, and we don't really we have not as a group. We have the consensus has never been to put our diabetics, for example, in firmly into that category that we would call immunocompromised. But we all as clinicians recognize these are patients who do have elements of immune impairment, and some of the bugs that we'll be considering when we think about causes of pneumonia certainly do have influences not only of the underlying disease itself, but sometimes some of the treatments, such as metformin, for example, may have some impacts on our clinical response to pneumonia therapy. Marcos, do you have any additional comments?
I think you elaborated fairly well. I think diabetes is definitely one of those conditions that appears on all the recommendations for vaccinations for all the possible respiratory pathogens, and therefore there are many observational studies that have suggested that diabetes is such a frequent disease, not so much with hypertension, but we saw that during COVID-19, for example, hypertension was an important disorder. but I agree 100%, is what to do with diabetic patients that happen to develop some sort of respiratory symptoms like the one that you're presenting.
Thank you.
Sorry, so for his social history, he's married and lives at home with his wife. His occupation is a businessman in the oil gas sector, but he does not have any personal exposures because he works in an office setting, and specifically no exposures to factories, farms, hot tubs, asbestos, or animals, no pets, never smoker, and no vaping, which I think many of us are finding it's very important to delineate when we talk to patients and ask them if they smoke. They say they don't smoke, but then they have a vape with them. And because for some people, they don't sort of equate the two. Social alcohol use, and he does take metformin, just to sort of relate back to what we were just speaking about, response to therapy. He has no known drug allergies. I think there's... Okay, I'm not sure if there was another question that was supposed to be here. Okay.
So while people are answering that, maybe Dr. Restrepo, anything jump out at you? I mean, in Calgary, many people are businessmen in oil and gas. So for us, that's not very unique, but anything jump out in your perspective?
Well, this happens to us in Texas too. I think what I would like to elaborate in social history is how good this social history was made. I have not really, this is not frequently a series of questions that I hear from my trainees on a regular basis when they present patients with community-acquired pneumonia. So you were acknowledging that there are several factors that could influence the possibility that this clinical presentation will be related with any exposure history of anything that the patient might be utilizing. So I think that that's kudos for the team that evaluated this patient, because that helped us with the differential diagnosis, especially with the exclusion of certain conditions that are very relevant in certain parts of the world.
Great, thank you. Keep going.
Okay. So as just to give a little bit more information, this productive cough, myalgia, and dyspnea had been going on for 7 days. It was associated with subjective fevers and night sweats. Notably, the patient did not have any hemoptysis, and the review of symptoms was otherwise negative. On further interview with the patient, he did say that he returned from a tour trip in Spain 10 days prior to the hospital presentation, but before the trip, he was in his usual state of health, and even for much of the trip, he felt well. And then it was more when he came home about a week later that he was feeling unwell and finally decided to seek medical assistance when the symptoms kind of kept going on, and rather than self-resolving. Vital signs on initial presentation: his temperature was 37.5 Celsius. His blood pressure was 131/75. He was tachycardic mildly to 110 beats per minute. His respiratory rate was 14 breaths per minute, and he was saturating 94% on 2 liters per minute via nasal cannula. And his physical exam was notable for decreased breath sounds and crackles at the bases bilaterally of the posterior lung fields, but the remainder of his exam was unremarkable. And so this here is his initial chest x-ray. This is a PA and lateral film, so we can switch back and forth just to show the initial PA film. And then he also had a lateral film as well. And so the next question will be, is sort of what are the notable findings on this chest x-ray?
So while our audience is voting, Dr. Evans, if you want to be in the hot seat, what are your thoughts about this x-ray? Oh, I think you're muted.
Sorry, I was muted and I have too many screens. So this patient appears to have infiltrates in the right base and probably a smaller element on the left base. Otherwise, it looks pretty good. I don't see a lot of change in the vasculature. I don't see much widening of the mediastinum. Heart looks otherwise normal. and the costophrenic angles are in pretty good shape, but he does seem to have right greater than left infiltrates.
Oh, looks like some technical difficulties. Question isn't launching, but that's all good. I think we got a good impression. We can keep going on. That's good.
Okay, so pertinent labs on admission, he had a white blood cell count elevated to 15.4 with a notable neutrophilic predominance. ANC was 13,500. There were no eosinophils on this peripheral lab draw. The CRP was elevated to 45, but all other labs were unremarkable. He was admitted initially under the hospitalist service with the diagnosis of community-acquired pneumonia and was started on treatment with ceftriaxone and azithromycin. And so the question I think that came next, just looking at my slides, would be, whether or not you agree with having started the patient on this particular antibiotic regimen.
Maybe we'll go to Dr. Restrepo. What are your thoughts about if that was what you would do, or any thoughts around that?
Well, I think the selection of antibiotics in this particular case seems to be very appropriate and consistent with the guidelines. So if you're considering that this patient is going to be hospitalized in the ward setting due to the non-so-severe community-acquired pneumonia, the selection between a beta-lactam such as ceftriaxone plus a macrolide, in this case azithromycin, seems to be according to the recommendations. The idea with this is that you will cover most of the bacterial pathogens that include Streptococcus pneumoniae and all the other gram-positive, gram-negatives, but you will also be able to really cover the atypicals, including Legionella, Mycoplasma, and Chlamydia. So you will have a broad spectrum coverage empirically, waiting for the results of the selection. Now, if the patient is in the floor service, the second alternative that the guidelines recommend is the utilization of a single fluoroquinolone. But if the patient is so severe that requires ICU level of care, is the combination therapy with a beta-lactam plus azithromycin versus the beta-lactam plus a fluoroquinolone as the second alternative according to the severe CAP guidelines. So I think this was a very appropriate selection empirically based on what we know so far from the patient. What do you think, Scott?
Marcos, I think that you have perfectly outlined the guidelines, and I agree that this was a guideline concordant selection of antibiotics.
Great, thank you. So respirology was consulted and completed the workup with a sputum culture, which was negative, and there was a BioFire amplification, nucleic acid amplification testing that was positive for Mycoplasma pneumonia. So I'm just going to go ahead and display here so you can see, of course, that a wide range of pathogens are tested for, and the only one that was positive was the Mycoplasma pneumonia. The patient did note on further interview that others on the tour bus during his trip to Spain had influenza-like illness symptoms. He was titrated off of oxygen with an oxygen saturation of 92% on room air and discharged on azithromycin. So the question next would be, do we agree with having discharged the patient on azithromycin monotherapy? Do we think that maybe we would have added another agent such as augmentin, or would we have prescribed levofloxacin instead as monotherapy? So just sort of thoughts about this, about the patient's discharge condition and discharge plan.
Maybe we'll go to Dr. Evans, remembering the patient is at altitude as well. So we are at a high altitude. And it looks like our questions are working.
Someone's already posted in the 92 below. So I actually think this was a relatively reasonable thing to do, because the patient had demonstrated significant clinical improvement, is what I'm gathering. That patient was febrile, generating sputum, had a significant oxygen requirement, and is now. So yes, I'm sorry, we now have the vote from the group, and I tend to agree with the group that this is not an unreasonable thing to do. In thinking about this slide, I do want to, I'm trying to contemplate whether this new knowledge that we have now of the trip to Spain, whether that impacts that decision. It's not, it's not something that comes up all the time. In general, my understanding, in terms of the molecular epidemiology of Spain is that it's relatively similar to the rest of Europe and to North America in terms of causative agents of CAP. There are some prior reports with Spain demonstrating a little bit higher rates of Legionella, which would go along nicely with him being on a tour, because of risks associated with hotels and tours and things of that nature. But you tested on the biofire for that as well, and didn't identify that. So I honestly don't have an objection to a patient who seems to be appropriately responding to guideline compliant antibiotics to be discharged on single agent azithromycin.
Dr.
Can I ask a question?
Yes.
For Alexandria. Alexandria, do we know what was the absolute lymphocyte count on this patient at presentation and whether an ABG was done? Because even if it is in the high altitude, that initial 2 liters per nasal cannula that was administered to the patient makes me concerned that the patient was hypoxemic at presentation that required to be placed on oxygenation. And maybe this 92 looks better than what it will have been. That's the only consideration on the clinical aspect that may have really determined for the decision to maybe observe him a little bit better rather than sending him home.
Yeah, I don't have the absolute lymphocyte count or a blood gas, but I too was struck by this is somebody who has no respiratory history. He's a never smoker, no significant exposures to biomass or things like that. And so although we don't have a baseline oxygen when he's not sick, it's kind of interesting that he ends up sort of at the very, very low end of an acceptable oxygen level for somebody who's not chronically hypercapnic, let's say, before and going home. So
very good. And the second question I have for you is the CRP of 45 really high for the lab record on your institution? Because for me, in this institution sounds high, but I don't know what it means on the lab sensitivity at your institution.
So Dr. Thornton, I don't know if you'd at my institution, a CRP of less than 3 is considered to be negative. So 45 would be somewhat of an elevation. I mean, certainly we've seen folks in the 100, 200, but I would say 45 for my institution's lab would be considered mildly elevated.
Yeah, so in Calgary, the upper limit of normal is 8, so 45 is elevated. Yeah. Great. Thank you.
Okay. So 48 hours after discharge, the patient re-presented to the hospital with worsening dyspnea. At this point, his vital signs were notable for an oxygen saturation of 78% on room air, requiring supplemental oxygen to be administered at 6 liters per minute via nasal cannula to achieve normal oxygen saturation. His physical exam was notable for inability to speak more than several words at a time, worsening respiratory effort, and noted accessory muscle use. He was readmitted under the respirology service, and this time he was initiated on tazobactam plus azithromycin again. And so the question, I'm not sure if it's going to load. Oh, great. Is sort of, again, whether we agree with this choice of antibiotics.
So as people are voting, Dr. Restrepo, what are your initial thoughts, given a very quick representation and quite unwell now at this point?
My goodness, this is a topic that I touch every single day with my residents in the ICU. I said, okay, guys, every time someone comes back with community acquired pneumonia, you always cover against everything. And here, most likely, even at my institution, they will have used vancomycin too, thinking that MRSA was the case. So I'm assuming that pip/tazo was considered with the possibility that we are dealing with a Pseudomonas aeruginosa that was untreated, but the patient didn't have any risk factors for Pseudomonas aeruginosa. So here we have several options. This is a patient that initially did not have many markers of severe disease. He has a few of them. Both of them are all pulmonary related. One is the hypoxemia that I think was present with the need of secondary oxygen therapy. And number two, the fact that he has infiltrates bilaterally, more predominantly on the lower base, but he also had on the upper base, particularly on the upper side and the lower base on the left. So this is a patient that could perfectly have progressed during the past 2 days and very unlikely secondary to Pseudomonas aeruginosa. So I think that my concern will be more with the history of Mycoplasma, that the patient is progressing and having a secondary sort of complication, and that this respiratory failure is possibly related to two main factors. One is the possibility of the Mycoplasma type 2 that developed this CARS toxin, that we are seeing more toxin liberation here, and we certainly needed to do something. But theoretically, the azithromycin should have been able to really cover for this one in the short period of time. The second alternative is the possibility that this Mycoplasma is not responding to the initial azithromycin therapy, or that we didn't really read that the patient was going to require further requirements of oxygen at the time of presentations. So that will be my take home there.
Thank you. Dr. Evans?
Yeah, you know, I obviously Marcos is correct in all that he said. I think the one consideration we didn't include was the possibility of an unidentified immune impairment on the part of the patient. That's just, you know, when you have a patient who's not responding as you expect, we had an identified pathogen, at least based on nucleic acid amplification testing, that we would expect to have been sensitive to azithromycin. I agree entirely with what Marcos had to say about the management of the antibiotics on the return to the hospital. But that would be the only contribution I would offer, which is that, you know, it's either the bug or it's the host, right? And that was just one consideration we didn't throw out there. I mean, we don't know what the absolute lymphocyte count was. You know, I'm presuming that, for example, he doesn't have HIV and it's unknown to us, or, you know, something of this nature. But there are host factors that are unknown, and sometimes we'll have patients who present with unusual infections as their initial presentation of their immunocompromise. So that's just something to keep in mind.
Great, thank you. Keep going.
Okay. So this was his chest x-ray at representation. So just to appreciate, once again, we have a PA and lateral. And so the next question, I think, is whether or not we think the x-ray has changed, or sort of is there a note of, you know, there are several findings, but kind of what is the most predominant finding?
Dr. Restrepo, will put you in the hot seat for interpretation this time.
Well, I think the area on the right base is definitely more consolidated compared to what we saw on the original chest X-ray. But I still see all the other interstitial markings that are towards the periphery, and now even more pronounced on the left side on both lungs. But in the left side, I see a lot. Now the perihilar area seems to be a little bit more prominent, but I would be very concerned that if we happen to do, or if we happen to have a CT scan, we will see something like that. Now, the left hemidiaphragm seems to be a little bit higher than the right. That is a little bit surprising. And it was originally about the same side, or it was probably less, and that suggesting that he has some bowel distension there that we didn't really notice at the beginning. But that would be it.
Thank
so
you.
worse.
Yes.
Worse. And the audience seems to agree. Worse. Yes.
Okay, so then we do have now a CT chest that was done. I just have some representative slices. I don't have the entire sort of video, but this was negative for PE, so you'll just have to take my word for it. But here's the, you know, the most prominent part of the pulmonary artery. And then I'm going to just show several axial cuts as we sort of progress down the levels. I'm sorry. And then I'll go back so everyone can see. And that's just, this is a coronal view to get a little bit more of an appreciation of the distribution and involvement of the lungs, and sort of, we note that it's more posterior, closer to the spine rather than anterior. And this is, I think, the really nicest picture. And so the question is, what is the most notable finding on the CT chest?
Dr. Evans, maybe we'll get your thoughts.
Sure.
We have
So
some
the CT has made really clear that this is really multifocal in nature. You know, we've got that impression looking at the chest X-ray, but now we see we see involvement throughout the lung. We did see some tree and bud in portions, but there's lots of micronodules, as well as some consolidation, especially down on that right base.
And maybe I can ask, while the audience is voting, maybe Dr. Restrepo, how do you differentiate, just for maybe the learners in the crowd, tree and bud versus miliary? How do you tease out that pattern?
My goodness, you gave me the hard one. No, I changed my answer like 3 times. I didn't know multilobar consolidation. Then I said, oh, okay, I also see tree and bud nodularity. Then miliary. Oh, it looks miliary too. So it was very, very hard. But I think all of the above. No, it is not crazy paving. That one, not atelectasis. But I can see that there are some areas that are suggested mostly on interstitial pulmonary infiltrates with a tree and bud, but the multiple small nodular infiltrates towards the periphery make you categorize it as a miliary pattern, particularly on this one. Although there are some nodules that are a little bit bigger than expected for the miliary pattern, but to my humble interpretation, that I'm not a radiologist, I think we can really see several of these changes. But I also believe that we still see that area of consolidation that was mainly on one of the pictures here. But I don't see that much air bronchogram, although it is a little bit suggested, as I initially thought that it was going to be more pronounced on what I saw on the chest X-ray.
Just one additional question or comment for the sake of the learners. You know, Marcos, you mentioned, you know, struggling with whether to call this miliary, and I sometimes have that same question. And just the other day, working with some of our learners, you know, found a paper that gave a nice rule of thumb, which is that 2/3 of the lungs are involved, and the nodules are all 4 millimeters or smaller. That's just one potential way to, you know, if you're trying to, you know, there are these classic examples with TB where you see just an infinite number of tiny nodules. But then we get things like this when it starts getting a little harder to understand what, you know, how to differentiate patterns of micronodules. Anyway, so that was one categorization we read a couple weeks ago.
That's very
helpful. What is the correct answer?
All of the above, I think. Actually, the CT report on this case actually commented on all those findings that were, apart from the crazy pig. So I think all of the above is a fair answer. All right, thank you.
Okay, so his supplemental oxygen requirements unfortunately continued to increase. He ended up on a high flow nasal cannula with an FiO2 of 50%. The ICU was consulted, and it was felt that he was stable enough to remain on the medicine floors with close observation. And so the infectious disease service was consulted. And I guess at this point, we'll say that they were giving some consideration of macrolide resistance because there had been such reports in Spain, which I think we had just touched upon a little bit earlier in our discussion. The patient was changed from azithromycin to a fluoroquinolone, in this case, levofloxacin, and the patient rapidly improved within 2 days, and he was discharged on room air after 5 days of therapy. And then he came for a follow-up at 6 weeks, after hospital discharge, and we can appreciate that his chest X-ray is significantly improved to really resolve the findings that we saw when he presented initially.
Maybe I'll just pause there and ask our two experts, now that the case is concluded. Dr. Evans, what are your thoughts? Would you have thought of Levo up front in hindsight of his travel history, or any thoughts about this case?
No, I mean, I mentioned earlier, some of the other considerations based on his travel history. We should get reasonable Legionella coverage also from azithromycin. I may have nonetheless begun with a respiratory fluoroquinolone, based on his recent travel history. We also, of course, fail to consider viral infections in that process too, which is also going to be a big impact when we have folks returning from international travel. But once again, the approach was guideline consistent, totally defensible, and unfortunately is we're seeing a manifestation of an increasing rate of resistance that wasn't necessarily anticipatable, and we shouldn't necessarily react to on a broad scale.
Very, very, very insightful thoughts. Dr. Restrepo, anything to add with the conclusion of the case?
Well, as I was mentioning to you and to my colleagues at the beginning, is I had to deal with a similar situation at home when my sister-in-law became sick with Mycoplasma pneumonia. Very similar presentation to this. The only big difference between her and this presentation was that she received amoxicillin clavulanic acid instead of azithromycin at the beginning. And the beta-lactams do not cover Mycoplasma, and she continued to worsen and went to high flow also. And then the question here is what to do. And she was coming from South America, not thinking that this was an area where highly resistant Mycoplasma was there, and not in the area of Texas where we usually do not see these things. So if the patient will have come from some of the Asian countries, that might have been a different story. But in her situation, we end up going with doxycycline plus azithromycin. And the rationale with that one was because we thought that in order for Mycoplasma to cause all this extensive disease, it might have been driven by the high CRP showing a lot of inflammation, suggesting that the CARS that is what the Mycoplasma 2 delivers was prominent there. So we wanted to have something that may control the toxin, such as a macrolide, with the potential that the macrolides alone are not doing the job. And we end up giving the doxycycline for that, and she responded fairly well to that one too. I think the selection here of a fluoroquinolone is very consistent with what it has been reported before, and I think is very appropriate, and very, very happy for the patient how well he responded to the change of therapy, which definitely suggests that was something not appropriately covered with that one.
Thank you.
So I just have then in the remainder of the session, I have a little bit of just a literature review. So I'm sure it's a review for many of the folks in the audience, but for learners such as myself and others in the audience, I hope this is somewhat helpful. So Mycoplasma pneumonia is a member of the class that derives from the Latin word meaning soft skin. And it was first isolated in tissue culture from the sputum of a patient with primary atypical pneumonia in 1944 by Eaton and colleagues. So it was actually known as the Eaton agent. It was initially thought to be a virus, as we'll see, because of its small size, until evidence demonstrated effectiveness of antibiotics against it in the early 1960s. Mycoplasmas themselves are the smallest self-replicating organisms by both cellular dimension and genome size that are capable of a cell-free existence. So an individual Mycoplasma pneumonia is only 1 to 2 micrometers long, by 0.1 by 0.2 wide, and the cell volume is less than 5% of that of a typical bacillus. The genome is only 684 genes. By comparison, E. coli has 4,300 genes. And so as a result, Mycoplasma pneumonia has limited biosynthetic capabilities, often requires complex medium supplementation for in vitro cultivation, and it has no ability to synthesize peptidoglycan walls because of the small size of its genome. It simply doesn't have any ability to do so. So as a result, it has a lack of rigid cell wall. It demonstrates pleomorphism, and so therefore it cannot be classified as a cocci or bacillus.
No peleen, por favor.
Oh, for others, do you mind just muting yourself, please? Thank you. Thank you.
Yeah. Mycoplasmas are primarily mucosal pathogens. Mycoplasma pneumonia in particular is an exclusively human pathogen. It attaches to the respiratory epithelium, and by doing so, it's protected from removal by the host mucociliary clearance mechanism because of its adherence, and it produces a variety of local cytotoxic effects. And this occurs via complex and specialized attachment organelle. So I thought this was kind of an interesting picture. It's a scanning electron micrograph of Mycoplasma pneumonia cells. And as you can see from the arrowheads, these are the terminal attachment structures with which it adheres to the respiratory epithelium. As I noted, it causes local cytotoxic effects by production of hydrogen peroxide and superoxide. Binding to toll-like receptor 2 is implicated, which subsequently leads to activation of inflammatory mediators, including cytokines. There is some data to suggest that the production of IL-17 may be associated with severity of disease, because as we noted, Mycoplasma pneumonia can cause a simple upper respiratory tract infection all the way to acute hypoxic respiratory failure due to pneumonia. There are two subtypes, which we mentioned earlier, type 1 and 2. Type 2 is the associated with higher expression of, CARDS toxin, community-acquired respiratory distress syndrome toxin, which is a virulence factor and leads to respiratory epithelial destruction. And it also forms a more robust biofilm as compared to type 1. Interesting to note that following acute infection, prolonged asymptomatic carriage can develop. So of course, that is a recurring problem with our, BioFire panel when we obtain those, that it, just because somebody's positive for Mycoplasma pneumonia does not mean that it's currently causing a problem for them. Obviously, in this case with our patient, he was quite sick and that was the only thing that came back positive. But just knowing that prolonged asymptomatic carriage can occur can help us in other patients where we aren't quite sure the significance of a positive Mycoplasma BioFire test. Most commonly in terms of manifestations is upper respiratory tract infection and acute bronchitis, marked by your typical cough, sore throat, rhinorrhea, and ear pain. Cough is typically a dominant symptom, but dyspnea is uncommon unless the patient has pneumonia. Pneumonia is less common. It is typically mild. Headache, malaise, low-grade fever, and sore throat. Cough, you can sometimes have pleuritic chest pain and dyspnea. Severe symptoms defined as hypoxemia, hypotension, altered mental status are less common compared to community-acquired pneumonia caused by other pathogens. So thinking about like strep pneumonia classically, or even Haemophilus. Course is typically mild with a full recovery. Occasionally, constitutional symptoms can last 1 to 2 weeks beyond resolution of respiratory illness. Fulminant cases resulting in respiratory failure and death have been reported, rare, but it happens, and they have actually been reported in previously healthy adults with no other concomitant medical problems or risk factors. The treatment, so we mentioned they have no cell walls, so there's a whole number of antibiotics that are not effective. Anything that works on inhibiting cell wall synthesis, your penicillins, your cephalosporins, are not effective against Mycoplasma because it has no cell wall. So instead, agents with activity are those that inhibit protein synthesis and translocation. So your macrolides and tetracyclines, such as doxycycline, and then your respiratory fluoroquinolones, such as levofloxacin and moxifloxacin. But macrolide resistance is observed in Mycoplasma in certain regions. Course of therapy is typically 5 to 7 days, but in severe cases, this can be extended to 7 to 14 days. And so to talk briefly about the resistance, which is macrolide resistant Mycoplasma pneumonia, MRMP, has been observed with increasing rates over the last several years, but there is significant regional variation, as we noted. It's caused by variants in the V region of the 23S rRNA gene. There was a big meta-analysis in 2022 of 153 studies across 26 countries looking at over 27,000 samples. And they noted that the proportion of macrolide-resistant Mycoplasma infections was increasing overall, and the highest proportion of cases was in the Western Pacific region. There is no published data from any countries in the WHO African region, so there is some limitation to the data available where we don't have a complete picture, but from the data that we do have, we're able to appreciate this map here, which again looks at the sort of global trends, and we see that the Western Pacific is quite affected. But if we look closely over, we see Italy, we see Spain and Portugal do have somewhat higher rates than other countries in Europe. And again, we see some, small elevation in the United States. We also have limited data from Central and South America as well. So again, the picture is a little bit incomplete. The worldwide proportion, you can appreciate the trend from over the last 20 years has gone up from 20% to nearly 80%. And when classified by WHO region, there is a significant increasing trend in the Western Pacific region, but not other regions. Again, understanding our data is limited. So for example, it went from, in the Western Pacific region, it went from 17.1% of infections were resistant to 76.5% in 2019. And that was a significant with a P of 0.01. This here is just a summary of the proportion of macrolide resistant infections worldwide. So you can appreciate in the first chart that this is globally. We do see an increasing proportion, but again, we see that that's mostly driven by increasing evidence of resistance in the Western Pacific region, in the region of the Americas, which really is mostly North America, because again, we have limited data in Central and South America. And the European region, we do see some occasional increases, but largely there's not been a statistically significant increase. You can also see some variation when stratifying by age group. The highest proportion of resistant infections was seen in studies comprising only children less than 18 years. If you look at adults only, that number drops from 37% to 15.9%, and it's 16.7% if you combine children and adults. So it's actually a little bit more common to see a resistant infection in children than in adults. And then the variation is also seen in the type of infection. A higher proportion of resistant infection is seen when including samples from patients with pneumonia versus respiratory tract infection, although notably there was no really statistically significant trend to say once you have a resistant mycoplasma, you definitely have more severe infection. That was not borne out by the data. This is also just looking at the mutation type. So there are two different variants, the A2063G versus the A2064G variant. And once again, we can kind of appreciate that overall, the former variant, the A2063G, is more common than the other. But the second variant, the latter one, is actually more of a problem in Europe in terms of increasing. And in the Western Pacific region, it's really the A2063G variant for whatever it's worth. In terms of in the United States, there was a 2017 national surveillance program run by the CDC that looked at 8 medical centers, and they found 367 cases of PCR-proven Mycoplasma pneumonia. So if we take a look at regions in the United States, we note that there are some differences as well. We see in the Northeast and the Southeast that there are some higher proportions rather than on the West Coast and in the Northwest, as well as in the central US. So the East really had the lion's share of resistant infections. And this here too looks at the prevalence stratified by year of specimen collection. So there was an increasing prevalence, but not statistically significant. Interestingly, and this is again from the United States data, that immune deficiency and malignancy was really the only thing that was really associated with somebody being more likely to have a mycoplasma, a macrolide resistant infection. Diabetes was not quite significant, but it was closer to being significant than many of the other conditions that they looked at, including CKD, sickle cell anemia, atherosclerotic cardiovascular disease, or even asthma. So it's interesting that, as expected, immune deficiency and malignancy will predispose somebody to a more resistant infection, but diabetes, which sort of straddles, we talk about, is it really immunosuppressive versus not, or to what degree? I think we all recognize it does have an effect on the immune system. That's sort of borne out by the data here. So it's interesting that our gentleman had a history of diabetes, and that may indeed have been somewhat of a risk factor between that and also, of course, his recent travel. Just to switch over now to Europe, we can see the rates of macrolide resistance here are fairly low in Sweden, Finland, and Denmark, and the Netherlands. But again, if we sort of appreciate the Mediterranean region, Italy is up to 26% in some studies. And again, Spain, not quite as high as Italy, but definitely one of the countries that does have a higher rate of macrolide resistance than some other countries in Europe. And then just sort of looking beyond, I thought this was interesting. Currently approved fluoroquinolones and tetracyclines. There are two antibiotics. One of them is lefamulin. Apologies if I'm mispronouncing that. So this is another fungal derivative, and it selectively binds to the A and P sites of the peptidyl transfer center of the prokaryotic 50S ribosomal unit. So again, it inhibits translocation and subsequent bacterial protein synthesis, which is all the agents that are going to be effective against mycoplasma, need to not be something that affects the cell wall because it doesn't have one. And this agent is effective against your macrolide resistant mycoplasma, MRSA, and E. faecium, but not E. faecalis, and it does have weak activity against anaerobic bacteria. It does have a USDA approval in 2019 for community-acquired bacterial pneumonia, and then pneumonoxacin, which is a non-fluorinated quinolone. This is currently undergoing clinical trials. This has shown significant bacteriostatic activity against macrolide resistant mycoplasma. And there's been a lot of work by Chinese scientists, because as we noted, that the rates of the resistance are particularly high in the Western Pacific, including in China. And that is all that I have for my review. So,
thank you so much, Dr. Imperator. What an amazing review of the literature and some novel stuff. Now that things are coming to a close, maybe I'll just open it up to kind of closing thoughts by Dr. Restrepo and Dr. Evans. There's some comments in the chat commenting what an excellent review and case. And then looks like there's a couple questions in the chat. So maybe I'll open it up to our experts to see.
Scott.
Deferring to me on the question of whether chest physiotherapy would have made a difference. I'm pretty confident we don't have an answer to that question. That certainly pulmonary toilet's important in helping our patients recover pre-morbid state, but I'm not sure that chest physiotherapy would have substantially improved the outcome in a patient who had a resistant organism.
I would like to add that in this particular case, sometimes with mycoplasma, the cough is very dry, so the patients do not have too much respiratory sputum production. Therefore, it's a little bit difficult to really assess, like with other pathogens like we usually deal with, like community-acquired pneumonia, regular pathogens like streptococcus pneumonia, etc., that they produce more, and then the mobilization of those secretions may facilitate the breathing.
Thank you. looks like there's another good question for both our experts. If we're aware of any PCR-based testing for resistance in the pipeline that could be used perhaps more in the clinical setting as opposed to research.
So, I mean, that's definitely, there are definitely nucleotide amplification testing studies that are underway for looking for resistance cassettes, basically. The problem is that you would have to include a tremendous number of them if you're doing sort of untargeted testing, the way that we are in something like BioFire, which is a large panel. So consequently, you're not going to get that right away. But the ability to do it is certainly there. I mean, that technology already has existed for quite some time. So, I mean, I do think that will be more readily available. But like I said, the problem with just sort of shotgunning that is that there are too many different ways that too many different bugs can generate resistance.
Absolutely. Okay, I don't see any more questions. Do either of you have any other closing thoughts or anything else to
I
add?
would like to add, what did we miss for the patient to become so sick? No, it is like one of those intriguing questions for our research group, and said, how in the world will have prevented that this patient will not have the outcome of initially requiring hospitalization? And one of the possibilities here is when we look at the curve 65 of the PSI, that patient was considered non-severe. So the decision of really send the patient home will have been there. One of the big critiques on the curve 65 is that it does not include the multilobar infiltrates nor the oxygenation. Therefore, this is when you really see this kind of patient on the second time, is whether this patient requires ICU level of care or not. And this patient had 2 out of all the criteria was the severe community acquired pneumonia criteria by the guidelines. The multilobar infiltrates and the oxygenation may have been those that are altered. That still doesn't make it at least 3 or more to really make it to the ICU level of care, but certainly requiring probably some PCU level of care, progressive care unit with more observation than any other patient, particularly those requiring high flow oxygen. So if you review the guidelines on severe community acquired pneumonia, I think the approach of utilizing high flow oxygen, it became more readily available during COVID-19. We all became more familiar with this methodology, and I think it was appropriately done on this particular case. So this was a very intriguing and important case with a pathogen that we usually don't see all the time in adults, not particularly developing such a severe turnaround after initiated on the appropriate therapy, calling to the attention to the possibility that resistance is definitely there and probably more than what we usually expect on patients with Mycoplasma. Does this mean that we should not be using azithromycin as the first-line agent next time when we see a patient with Mycoplasma? Probably not, because many of these patients will still receive the CPAC and they do particularly fine. So this is why I would like to really echo what Dr. Evans mentioned about possibly something is particularly on his immunological status of this patient. And this is why I thought that this patient should be evaluated somehow, because this is not the most normal presentation of a patient with Mycoplasma, nor in an adult patient that seems to be just not having too many comorbidities.
Wow, that is a wonderful way to end our session with some thoughtful thoughts. I think we will probably wrap it up there. It's just almost to the hour. So thank you so much, Dr. Imperato, for a great case, really, really excellent literature review. Big thanks to Dr. Restrepo and Dr. Evans for their very thoughtful expertise. I think we all learned a lot. It was really great to have such great audience participation. And yeah, hopefully we will catch you at our next sessions to come.
Okay, thank you, everyone.
Thank you to both of you and for everyone in our organizing team at ATS. Really appreciate it, and all of you to attend it. Thank you for the invitation. Bye-bye.
Thank you.